You all know that traditionally renal cell cancer is considered to be a radio-resistant tumor, and usual conventional radiotherapy using 2-gray perfraction doesn't affect on the disease. At the same time, it was shown that stereotactic radiosurgery is highly effective for those patients with renal cell cancer who developed brain metastasis. In this group of patients, local control rate is above 90% and local recurrence rate is very low. In last years, development of radiotherapy equipment, I mean IMRT, IGRT, VMAT, allowed us to deliver high doses of radiation not only to intracranial but also to extracranial and even to the moving targets. That's why it is of great interest at present time if SBRT can be useful for treating primary tumor in patients with renal cell cancer. Still, surgery is the treatment of choice. But there is a group of patients for whom surgery is not possible. Elderly patients, patients with poor performance status, patients with comorbidities. And there is one special group of patients, patients with a tumor of a single kidney. There are not so many papers yet describing use of SBRT in these patients, and one of them, you can see on the slide, it was published in 2009. 6 patients were treated for metastatic lesions of kidney cancer, and 1 patient for the primary tumor of the kidney. 7 patients were treated. You can see on this picture the localization of the tumor. Hypofraction schedules with 3 or 4 fractions given every second day were used. The median follow-up was quite long, 49 months, and some patients were followed up to 70 months. It's a good period of follow-up. Dose to organ at risk to the spared part of the kidney was from 9 to 12 gray. And if we recalculate this dose using linear quadratic equation, we will see that it's equivalent of 10 to 14 gray in 2-gray perfraction way, if alpha beta is 10. So it's not a large dose for the spared kidney. And the local control was achieved in 6 patients. 1 patient had local progression and was re-irradiated, and there was achieved local control also. Toxicity grade was low, and 1-2 grade toxicity was seen in 4 patients. It was nausea and fatigue. None of these patients needed dialysis during follow-up, and again pay attention that median follow-up is up to 49 months, and some patients were followed up to 70 months. The main problem when we are talking about kidney irradiation, about single kidney irradiation, is the dose constraints. What constraints can we use if we want to spare the kidney? We have some from conventional irradiation. These are EMAMI constraints given in 1991. And here we can see that 1/3 of the kidney can get up to 50 gray without serious risk of renal failure. And the whole kidney can get up to 23 gray and with a very low risk of renal insufficiency. There are also Quantec constraints which are similar to those of EMAMI. The mean dose is up to 18 gray with low risk of complications. And there is one interesting study considering radiobiological effects and assessment of regional change in renal function in response to single fraction of 26 gray. This is a case report of a patient with a solitary kidney. Follow-up of kidney function post-treatment was determined through renal scan with technetium. And here you can see the renal scan picture. The green line shows 13 gray zone. These scans indicate that renal cortical function is spared to regions with prescribed radiation dose below 13 gray. Once again, the green line is 13 gray, and if we recalculate 13 gray in single fraction to conventional irradiation, it will be about 25 gray. So we can see that 20-25 gray in conventional way is appropriate to spare the kidney. based on measurements of glomerular filtration rate, renal function declined rapidly during first 3 months in this case. Then there was a phase of plateau, and the decrease stopped about 18 months after the treatment. And the decrease was for about 50% from the starting point. And here on these curves you can see the difference in cortical function. The black line is the region where 5 gray were delivered, red line up to 10 gray, and green line up to 15 gray. And you can see here there is the same difference, the same change in cortical function. And if you can see, if you will look at the regions with the dose above 15 gray, 1520 and 2025, we can see a rapid decrease of cortical function. So we can say that the dose of 13 gray is applicable in this case. And of course we have some constraints for SBRT. The only constraints are given by Timmerman in 2008. But it's not all the time we can use these constraints, because the dose is given for 200 cubic milliliters, and if we are talking about the irradiation of a single kidney or a resected single kidney, it's sometimes the spared part is much less than 200 milliliters. So of course we need some other constraints to use. And in order to prove the statement that SBRT could be really useful and safe in kidney cancer, I'd like to show a clinical case from our own practice. It's a patient who came to us in July 2013. A year before that, he had surgery because of synchronous bilateral kidney cancer, right side nephrectomy and left side nephron sparing surgery. And in a year after surgery, a patient discovered tumor recurrence. He came to us with macrohematuria. We performed biopsy, and we verified that it was clear cell renal cell carcinoma. You can see it on the MRI here. And what are the potential treatment options for this patient? Tyrosine kinase inhibitors, systemic treatment, but this patient had only one lesion, and there were no any metastatic spread in lung or anywhere else. And so we didn't want to give a systemic treatment in this case. And another option was nephrectomy followed by hemodialysis, but patient refused this way, and so we decided to try and to spare the kidney. We have chosen the way of 36 gray in 3 fractions. You can see a huge tumor. This is a tumor in the already resected kidney by that time. It's about 150 cubic centimeters, and it's a little bit more than the rest part of the kidney. Here you can see fiducials. And the aim was to spare the rest part of the kidney, so you can see the steep dose gradient in this way. So the volume was 150 cubic centimeters plus 5 millimeters to PTV. Prescribed dose was 79%, and the mean dose to the kidney was 13 gray. We have 16 gray in 3 fractions to 1/3. You can see 30% of the volume gets 16 gray in 3 fractions. And if we recalculate this to conventional fractionation, we will get something about 20 gray. And as we know from EMAMI constraints, the dose to 1/3 could be up to 50 gray. So we naturally fit those constraints. And 2 years after treatment, we saw the tumor shrinkage and good local control. Of course, renal function was a little bit lower than before treatment, but still patient didn't need dialysis. But it's not the end of the case, because in September 2015, patient came to us again again with complaints for macrohematuria. And during investigation, we revealed a renal pelvis neoplasm. We performed MRI. In the upper third of the left kidney was a pathological mass without any abnormality on diffuse weighted images. That was the tumor which we irradiated 2 years before. But in the projection of the left kidney pelvis, there was some tumor with pathological signal on diffuse weighted MRI. We performed pyeloscopy twice, but biopsy was uninformative and complete endoscopic removal wasn't possible, unfortunately. And in December, we repeated MRI, and we again saw the tumor mass, but it increased in size up to 3 centimeters. So you can see it on the MRI scan, this huge mass in the renal pelvis. Again, potential treatment options were systemic treatment or nephrectomy followed by hemodialysis. Due to the same reasons as 2 years ago, we refused systemic treatment and patients refused hemodialysis, and we decided to re-irradiate. A little bit more mild way was chosen, 40 gray in 5 fractions. You see the patient was treated in prone because it was cyberknife and we wanted to spare intestines and colon. And here you can see the urethral stent in the pelvis of the kidney. The CTV volume at this time was about 22 cubic centimeters plus 5 millimeters for PTV. 40 gray in 5 fractions, and again mean dose to the rest part of the kidney was about 14 gray, and 1/3 of the kidney got 17.5 gray in 5 fractions, and if we recalculate to standard fractionation, it will be again about 20 gray, so we fit the dose constraints again. So you can see that this method, SBRT, let us to spare the left part of the kidney even if it's very small. So 4 months later, we can see the shrinkage of the tumor. Hematuria resolved in about 2 weeks after treatment. Of course, glomerular filtration rate is low in this patient, and of course, creatinine is about 300, 350, but this patient still doesn't need hemodialysis. What are potential difficulties in this case? The risk of overdose for small bowel and colon, and that's why we treated this patient in prone. Of course, if we used TrueBeam, for example, we will treat in supine, but this was cyberknife, so we treated in prone. Renal pelvis fibrosis is possible complication. Maybe we will see it in this patient later, but we can use ureteral stent and resolve it, I think. And of course, there is a risk of progressive renal failure. But anyway, total follow-up of period for this patient is 51 months since first SBRT, and it is 25 months after second SBRT. The patient still doesn't need dialysis, he feels fine, and we really hope and we really think that SBRT can be considered a treatment of choice instead of nephrectomy with hemodialysis for patients with a tumor of the single kidney. And in the end, I would like to show you this slide. This is a renal scan. This picture we usually see in a year or year and a half after SBRT. You can see no blood flow in the irradiated region. So this really works. Thank you for attention.